So I thought we would speak today about female anterior cruciate ligament injuries, or so-called ACL injuries, really one of the most common sports medicine injuries that occurs. So the focus of today's lecture is going to be why do they occur and how can we prevent them. So ACL injuries have increased in female athletes in particular. And this is really because of Title IX, which was an Education Amendment Act that was passed in 1972 that mandated all schools receiving federal funding that they must provide equal opportunities for women's sports. And you can see how much of an impact this actually had on the amount of female participants in sports. So from 1971 to 1972, there were just under 300,000 female participants in sports-related activities. And then after the act, looking at the numbers again, from 1998 to 1999, over 2.5 million female participants. So obviously this was a really big push and one of the major causes for having so many more female participants and subsequently more injuries. So what is the incidence of ACL injuries? Well, looking at data from the NCAA, greater than 150,000 female participants in sports-related activities, and the Federation of State High School Association has greater than 3.2 million female athletes. So just looking at high school and college athletes, there are over 50,000 ACL injuries just in female athletes. And I put down there are about 250,000 ACL injuries overall in the United States per year. So really, an epidemic kind of thing, a very significant injury. About 1 in 20 at the collegiate level and about 1 in 50 to 100 at the high school levels. Females, 3 times more common in soccer and 4 times more common in basketball, and this is compared to males. So why is this problem such a big deal for female athletes, and it really a devastating injury that'll impact career, impact scholarship, impact the ability to participate just in recreational sports. So just running through some of the potential causes. It has been proposed that environment is a cause, and again, there's no real consensus on this. There are anatomic issues that have been proposed, and some of the data on this is equivocal. There's hormonal postulations, and there is some evidence to suggest that this may be true. And neuromuscular, which really seems to be the most major risk factor in ACL injuries. So looking at environmental evidence first, what is footwear? Does it have any impact on this particular type of injuries? Well, some have suggested that high friction may cause the foot to catch or stop, and then having this what we call non-contact mechanism, where this is the mechanism of the majority of an injury. So it's usually not someone just coming in and hitting someone. It's usually taking the foot, planting, pivoting wrong, and then the ACL pops. And there was a study in 2003 that showed that handball on artificial floor versus wood floor had a higher incidence of ACL injuries, again supporting that issue that maybe higher friction may cause this to be a problem. And then there was another study done in 1999 showing that there was a higher incidence of ACL injuries in Australian rules football during lower rainfall. So again, these are some of the studies out there, and again, we haven't really come to any definitive conclusion yet, but maybe an issue. What is some of the anatomic evidence? Well, looking at something called the notch width, which if you look on a radiograph is the space where the ACL sits. And they've looked at measurements looking whether this notch is narrow and maybe somehow this pinches off or causes the ACL to be at higher risk. And again, you have to take some of these studies into sort of question to some degree, because there is definitely issues with reliability and validity of X-ray measurements. Were all the X-rays taken in the same position? Were they all taken with the same X-ray machine, the same radiographic beam? So there was one study done in 1994 that suggested that if the notch width was 17 millimeters or less, there was the person was 6 times more susceptible to an injury. And then, however, there were other studies in American Journal of Sports Medicine in 1997 and 1993 that showed no correlation at all. So a little bit of equivocal evidence there. The one most compelling study that really looked at this, that really supports that the notch width may play a role, and showing that anatomy is a big deal here, is they looked at people with bilateral ACL tears, and it was shown that the notch width in bilateral ACL tears is less than in unilateral tears. So when they measured people's knees, In the bilateral ACL group, there was 12.8 millimeters, 13.8 millimeters in the unilateral, and 14.5 in the control. And this did show a significant difference in this study. Again, looking at some more anatomic evidence. This was a study published in the American Journal of Sports Medicine in 2003 looking at non-contact ACL injuries versus no injury at all. And the injured group had a higher body weight, higher body mass index, higher generalized laxity. They had a lower notch width that we just talked about, and a lower eminence width, which was the area in the knee between the tibial spines. And they sort of wanted to look and try to see if they could predict who was at risk for this non-contact ACL injury. And what they came up with is sort of this formula to say that if you have a body mass index greater than 1 standard deviation above normal, if you have a narrow notch, and if you have a generalized ligamentous laxity, loose collagen, this predicted actually 75% of ACL injuries. So really, there is some compelling evidence that if you have some of these things, that you're definitely at a at-risk state for ACL injuries, especially with playing a high-risk sport such as soccer, basketball, lacrosse is a big one right now, and skiing. What is the hormonal evidence? And again, this is very interesting, and there's a lot of new research coming out in this area right now. One thing that we do know is that there is some sort of a role for hormones playing a role here, especially with the female athletes. And we know this because prior to maturation, females and males have similar forces and motions about the knee. However, once females reach maturity, there's this increased dynamic valgus and decreased flexor torques when they measured knees. And this plays a huge role in ACL injuries. So what is really the mechanism? Well, we don't really know. We know that estrogen receptors are present in human ACL fibroblasts. We know that collagen synthesis appears to become reduced with increasing local estradiol concentrations. Now, this was shown in two separate studies. However, there was another study done in the Journal of Physiological Endocrinology in 2006 that showed that estrogen and its receptors do not affect ACL mechanical properties. So again, some compelling evidence for it, but then some equivocal as well. So the thought process is that estrogen may affect active restraints through a neuromuscular type pathway. We know that the menstrual cycle affects motor control and muscle strength. During ovulation, it's been measured that there's an increased quad strength and slower muscle relaxation. And we know that this increased quad strength and compared to increased hamstring strength is one of the postulated mechanisms in sustaining an ACL injury. Females tend to be quad dominant, landing more during sports with a stiff-legged sort of planting motion, not contracting the hamstrings, and that puts increased stress on the ACL. When we looked at when ACL injuries are occurring, it seemed that all studies, except one in the literature, favored ACL injuries in the pre-ovulatory phase. So there is something about our hormones and some effect on laxity of the ACL ligament or through a neuromuscular control pathway that I just mentioned where the muscles are functioning dynamically different. So again, something's going on here because ACL injuries are seen more commonly in the preovulatory phase. We also looked at oral contraceptives or no oral contraceptives, and this really did not impact the outcome at all. Another conclusions of the study were that those on oral contraceptives showed less laxity than non-oral contraceptives, but not less ACL tears. So although those on oral contraceptives, they maybe had a little bit of a tighter ACL by feel, this really didn't translate into less ACL injuries, so couldn't really take that another step and recommend oral contraceptives to prevent ACL injuries. That would be a far reach at this point. Some more hormonal evidence. There was a great study done in the American Journal of Sports Medicine in 2006 that evaluated female alpine skiers with ACL injuries, and they used control subjects. So people would ski, they would blow out their ACL on a mountain, they would come down and they would measure serum estrogen and progesterone levels at the time of injury. And the odds of injury, again, were significantly greater in this preovulatory phase, 57% versus 36%. More hormonal evidence. Another study out in the American Journal of Sports Medicine in 2007 examined hip and knee loading patterns at the different phases of menstrual cycle. They looked at horizontal and vertical jumps and showed that there was no difference in moments or knee angles at different phases of the menstrual cycle. And again, oral contraceptives or no oral contraceptives made no difference. However, there was a lot of limitations on this study. The models, there was a lot of intersubject variability, there was a small sample size, and each subject only did 2 trials. So again, taking this into the lab didn't really show it, but if you look clinically, all the studies seem to support some sort of evidence. So again, what can we what is the take-home message about hormonal evidence? Well, female athletes may be more predisposed to ACL injuries during the preovulatory phase. Athletes on oral contraceptives show lower impact forces, reduced torques at the knee, increased hamstring to quadricep ratio, and a decreased knee laxity. However, the use of oral contraceptives in combination with neuromuscular training may increase dynamic stability of the knee. But again, we need larger studies, we need validated questionnaires, and we need a lot more to just go out and make that broad recommendation about oral contraceptives at this point. Some of the most compelling evidence about ACL injuries and why they occur seems to be something about a neuromuscular control. In neuromuscular control, what that means is an afferent signal which causes activation of dynamic restraints. And we know that there are gender differences in motion patterns, landing position, as well as joint forces. So how does this neuromuscular control come into play? Well, we know that the hip is linked to the knee, and we also know that the gluteus medius and the hamstrings are weaker. And what this does is this makes females land from a jump more upright, so more with a stiff-legged knee gait, decreased ham and quad recruitment, and then they have the inability to keep their hip abducted because of the weaker gluteus medius. And this sets up for an absolute ACL injury. Houston, back in 1996, he actually coined the term quadriceps dominant. And this was, again, females, they contract their quadriceps, the hamstrings lag behind. And we know that anterior translation at low knee flexion angles increases the load on the ACL ligament, which is why it's so important to train those hamstrings to work and not just be quad dominant. One study done in the American Journal of Sports Medicine in 2005 looked at some biomechanical evidence. And what they did was they looked at 3D kinematics jump landing tests. And in their study, 9 of 205 females sustained ACL ruptures. They looked at knee abduction angle, and they also looked at max knee flexion angle. And they noticed that for knee abduction angle, there was an 8% greater in the ACL injured, and max knee flexion angle 10% less, so that straight leg again in the injured. So again, the knee abduction moment actually predicted ACL injury in this cohort with 73% specificity and 78 sensitivity. So this dynamic valgus, or straight leg, in addition, seems to be one of the primary predictors of ACL injuries. And again, this is just a diagram showing this sort of position of vulnerability compared to a safety position. So looking at the position of vulnerability, the knee is flexed, it's in valgus, the foot is externally rotated outward. And if you look at the safety position, this is a flexed neutral knee with good hamstring recruitment. That's a safety position. So you can see also on the bottom that inset. The preferred is to land with that bent knee gait versus that abduction or valgus moment on the knee. Another thing that's come into recent play also is the role of core stability, which also falls under biomechanical evidence, and that this may have a role in prevention of ACL injuries. So the lumbopelvic musculature is responsible for maintaining trunk control. And what this study did was it looked at 277 college athletes and noticed that trunk displacement was greater in athletes with ACL injuries. And this was interestingly only seen in female athletes, suggesting that core stability and prevention of this trunk displacement may play a role in being able to help prevent these injuries. So moving into what can we do about this problem. This is obviously an epidemic. It causes a significant impact on female athletes' lives. And fortunately, there are things called ACL prevention programs. And they were developed all the way back in the late 80s, Henning's program in 1989, Mendelbaum's PEP program in 1999. There are a whole host of programs. And the good news is that they all appear to be extremely effective at reducing ACL injuries. And they primarily affect this neuromuscular or biomechanical problem. The environment, in terms of footwear, we may be able to control that a little bit, but again, evidence is sort of equivocal at this point. Hormonal, there's not a lot at this point that we can make broad recommendations about what to do. And anatomic evidence, obviously we can have control over our body weight and our BMI, but things such as generalized ligamentous laxity and our notch width, we really can't control that. We are who we are. We were born that way. So how do these ACL prevention programs work? Well, they work through neuromuscular and proprioceptive training, and they improve feed-forward mechanism. So basically, there are 4 imbalances seen more commonly in female athletes, and all of these imbalances can be improved, thus reducing injury. So females are, number 1, ligament dominant. They allow stress on their ligaments prior to muscle activation. So we're not allowing our muscles, our quadriceps and our hamstrings, to fire enough, and all that stress is being taken up by the ligaments. We allow ground reactive force to direct motion, and again, this can lead to that dynamic valgus instability, which causes an ACL rupture. Females are also quadriceps dominant, which I've mentioned before. They tend to activate their knee extensors preferentially over their knee flexors, which again may lead to increased anterior tibial translation and stress on the ACL ligament. Females are also leg dominant, so one limb is usually stronger than the other. And this, again, places both limbs at risk. The weaker cannot dissipate all the forces, and the stronger may be subject to higher torques, thus causing injury. And the fourth thing is, again, trunk dominance. So this increased motion about the body center of mass. And in females, there's increased lateral trunk flexion, which increases the lever arm to the center of the knee, and again, may increase this valgus loading of the knee. So again, there are a whole host of ACL prevention programs, and they really do seem to be effective. The PEP program the study was reported in American Journal of Sports Medicine. This was a non-randomized study initially that looked at female soccer athletes, and they showed a 74 to 88 reduction in ACL injuries, which is huge. A randomized study later showed a significant difference in re-tear of ACL by non-contact injury, and there was a trend towards a decrease in other groups. Another ACL prevention program study was published in the Journal of Athletic Training in 2006. And what they did, they pooled results of about 5 studies to determine numbers need to treat and the relative risk reduction. So what they came with, sort of the formula that they came up with, was to prevent 1 non-contact injury, 89 athletes need to participate, and the risk reduction was 70% among participants. So this is huge. This is a big impact. So what are these ACL prevention programs consist of? Well, the ideal program includes a combination of stretching, strengthening, plyometrics, agility, education, and verbal feedback and cues. Timing, you only really need about 10 to 20 minutes 3 times a week preseason and 1 time weekly in season. And again, there are so many different programs out there, and some of them include all of the stretching, strengthening, plyometrics. Some of them include some of it. Some of them are 3 times a week. Some are 2 times a week. So there is definitely variability, but something at this point seems to be better than nothing. And again, these are all the studies out there looking, and some are non-randomized, but there are some good randomized studies that show reduction in ACL injuries. Obviously, there are some weaknesses in the study, which if the study was specific for example, soccer, we can't extrapolate that to obviously to all other sports. In some of the studies, there was a low compliance rate. And again, in some of the studies, they did not look at contact versus non-contact. So we know that these ACL prevention programs seem to work for the non-contact mechanism, but how do they do if you just get hit? Are you still at the same risk? And some of the studies did have limited subjects. The most recent study actually just came out just right before I was going to give this lecture, which is perfect. A meta-analysis came out just this last month in American Journal of Sports Medicine. And what they did was they pooled 8 cohort and 6 randomized controlled trials. There was 27,000 participants in ACL prevention programs. And what they concluded that neuromuscular and education interventions reduced ACL injuries by about 50%. And again, there were some weaknesses. There are obviously variable training programs, so all the studies did not use the exact same amount of weeks and the same amount of days. Some of them used more verbal cues, and some used more stretching, and there was some variability, but again, something better than nothing. And some studies did have a low incidence of ACL injuries. Maybe their numbers weren't big enough. So again, there's many unanswered questions for this problem. What is the true mechanism of an ACL injury? Is it sport specific? And why does this occur? Is the mechanism gender specific? Does fatigue negate the benefit of an ACL program? So if you're tired and you're playing in your third sort of, game of the week, or you've been playing, too many minutes in a particular game, well, does an ACL program help you at that time prevent an injury? We don't know the answers to those questions. And again, how do successful ACL programs work? And then what are the common threads between these programs? So again, a lot of unanswered questions, but some really interesting stuff out in the literature now. We know that we can make a difference. The biggest thing is getting promoting the education of these ACL injury programs, getting coaches on board, getting parents on board, getting the athletes on board, and really just taking that extra time instead of just focusing on the sport-specific game, but taking an extra 10 to 15 minutes a few times a week to really work on those components to prevent ACL injuries. Thank you.